I'm James Sutton. This is Road to Recovery. I'm a person in long-term recovery. And my special guest today is Emily Brown, who's the Ending the HIV Epidemic Program Manager at Montgomery County Health and Human Services. Hi, Emily, welcome.
Thank you so much, James. Hi, everybody. Great to be here.
So Emily, I was going to say she's the new manager, but she's actually, this is the first time we've had this position. So we're so glad that we have more help in that area because we certainly need it in Montgomery County. And I looked at your bio, and you really, you have a BA in political science and a master's in what?
In public policy.
Public policy.
Yep.
So why did you choose the work that you do?
Well, I will say I kind of, thanks for the question. I kind of landed in public policy because I love to think about less so individual behaviors and more so how the structures that build our environments, the policies, the traditions, the practices guide the way that we behave to each other, and especially in health. So yeah, policy is really interesting to me. And I think, you know, nowadays, like with COVID, we can think about individual behaviors like masks, but we can also think about universal healthcare or other policies that underpin how we go about doing what we do that might protect us or keep us safe or harm us from epidemics like COVID and HIV. So I was indoctrinated early to think about policy as a really important part of health, and yeah, just continues to fascinate me.
Good. Well, we're glad to have you, you
Thanks.
know, working on a systemic level, not just individual level. And also I looked at your bio, and you've been working with youth a lot, and a lot of people are gun shy of working with youth because youth can be such a challenging population. And can you share a little bit about your experience working with youth?
Yeah, I think people are right to be gun shy about working with young people because young people and I think youth exists to challenge us and to shift paradigms and to take risks, and it can be really difficult to sit in front of a really intelligent young person who has no reason to filter what they're saying and to really listen and to think clearly about what they're telling us. So it can be scary and threatening. I love working with young people because it keeps me thinking in a space of innovation. It helps remind me not to get defensive about new ideas. And gosh, I know it's really tough sometimes. But yeah, I wouldn't have it any other way. And I think, I don't know, I mean, when it comes to sexual health, it's really important that young people are learning from a really young age, probably a lot younger than most of us are comfortable talking about it, how to stay safe. And nothing makes me happier than answering questions that young people have about their own lives and their own bodies that everyone else is afraid to tell them. So it's pushing the envelope a little bit, but I just think their lives are worth it and they deserve that information.
Right. Yeah, I agree. That's one of the areas that we've started to spend more time exploring in the treatment center and the jail also is sexual health and recovery. I know you mainly work with the HIV education, but a lot of times addiction and HIV overlap. And I know that that's a lot of people a lot of therapists, let's say, a lot of clinicians don't go into talking about sexual health. You know, yeah. They may not be comfortable themselves, or they may be challenged by the questions, but you know, that's a very important topic for people recovering from substance use disorder, as well as the prevention with HIV.
Absolutely. And it actually, one thing I love about your work, James, and the work that you highlight here in the county is that a lot of it is peer driven by people in long-term recovery. And my work, we love to uplift the work of peers, people living with HIV, and their work in sexual health and recovery, and at that intersection is so critical. And I think part of it is because our clinicians As much as they're wonderful people who have a lot of education and a lot of biomedical skills, they weren't necessarily challenged in school to have those hard conversations. And there's something about peers, the relatability, the taking stigma head on and saying, this is who I am, this is what I've been through, that adds something to healthcare and recovery and sexual health that a clinician can't and maybe shouldn't add. So I just have so much respect for anyone who has come through an experience and said, I want to add my voice to recovery for other people. And sexual health is, I don't know. I mean, like, I haven't met that many clinicians in my life who do it right. It's like, I can talk to you about your earache, your arm ache, you know, your lungs, but once you get into certain regions of the body, it's like they don't exist anymore. And you know what? They do exist, and they're part of us. And I don't know, that really bothers me that we don't see more clinicians taking responsibility for that as part of health. And so thankfully, we have peers out there who are filling that gap, who are having hard conversations about addiction, about HIV stigma, a lot of stigma around drug use to begin with, and you know, and being part of a healthcare ecosystem. So let's hope in the future we value peers with more than just shout outs, and give them the salary and benefits they deserve as part of our healthcare ecosystem.
Hey, thank you so much for that last piece was very important, because we really we're not giving the peers what they've earned. You know, they really are such a valuable component to the treatment regimen, you know.
Absolutely. And I mean, I've seen the healing that peers provide firsthand. If I had to choose between linking someone with a doctor immediately after a significant diagnosis, or someone that has been there, oftentimes I need that buffer of a person who has felt that exact experience before. And you can't really put a price tag on that, but you can definitely put more of a salary and benefits than the average peer makes in America today.
Right.
So,
I mean,
anyway.
that's so, you know, it's so important. You know, I found that connection, you know, is one of the most important components, if not the most, in a therapeutic relationship. If we don't have a connection with the person, then they're not going to get services. They're not going to come back. They're not going to, you know, access services, whether it's HIV or, you know, treatment for an addiction. So we want them to keep coming back.
Absolutely. And I'm just, I'm so thankful that peer paradigms of service are starting to gain traction at a higher level, and more people are thinking about them and thinking about all of the benefits. And frankly, you know, just driving the national dialogue about HIV stigma, about harm reduction in drug use, about trauma paradigms, all these things that we talk about in this field that you know, that are super important and central to us doing a good job at serving folks. Those all came from people with lived experience. All those ideas came from often the unpaid work of people with lived experience. So I think about that a lot, and I hope that my work at the end of all of this reflects that as much as possible, because I wouldn't be where I am today if it wasn't for people living with HIV holding me accountable and reminding me of constantly of that unpaid work, of the labor of organizing people to change the systems that sometimes are built not to care for them. Right. So I appreciate that a lot.
Yeah, you know, I had a personal experience early in recovery. I think I had less than a year clean, and it was the NA meet. I got clean in Baltimore, and it was the NA meeting I used to go to in Park Heights in Baltimore. And it was a guy who was actually full-blown AIDS, and he had an ostomy bag on that he had, and he used to ride the bus to the meeting, and I had a car, and he taught me how to say anonymity. And you know, I used to go to the meeting because I just say, like, if this guy with the ostomy bag and full-blown AIDS could catch the bus and go to an NA meeting, then me with the car has no excuse, right? So he kept me, he motivated me to keep coming back. I mean, and that's a life lesson I got from him. And he passed, you know, but that day he helped me to get to where I'm at today, you know?
I love that.
There's a lot of heroes out here, unsung heroes that are people in recovery from addiction and from HIV.
Absolutely. And oh my gosh, I mean, there's so much overlap, like you said before, and all the ties between HIV risk and HIV healthcare and substance use and addiction. There's so many ties in ways that are unexpected. But the thing that always stood out to me are the stories like you were just talking about, how there's I mean, some of the early support group models for people living with HIV to connect to each other were rooted in some of the early paradigms of mutual support for recovery. And gosh, I mean, that camaraderie, that support, that example setting, learning together how to navigate care systems when you have a really difficult situation happening in your life, how to talk to your family and friends about something really stigmatized, all of that stuff kind of blends together. And so a ton of the like folks that I knew when I first started working in this field were people in long-term recovery who are also living with HIV. And it was really heartwarming to see folks learning from each other. And, you know, it's great to see that that's being recognized as the life-saving intervention that it is, obviously, as your story just illustrated.
Yeah, truly. And even the broader, you know, I'm a part of Faces and Voices in Recovery, and, you know, that's an addiction, you know, advocacy group on a national level. And we really started addiction marches based on the marches that the HIV community were doing to advocate for, you know, changes in policy, you know. So we got that cue, the success of the people in the HIV community advocating for themselves. The addiction community got out, you know, kind of, okay, this is a good opportunity to do some advocacy work on Capitol Hill and nationally to get more treatment, to get more treatment rather than criminal outcomes for people who used, you know, substance use disorder, you know.
I love it. I love that. And there's so many movements like that I think, you know, it's great to see borrowing from each other. The disability rights movement, HIV, people formerly incarcerated folks. I live for that. I'm so excited that chain of inspiration of organizing people who are impacted by something the rest of us not only don't have, but don't talk about or pretend doesn't exist, like this bizarre tendency that we have in the mainstream of completely ignoring people with disabilities, people with HIV. I mean, the federal government didn't even say the word AIDS for years after we discovered that there were people dying of AIDS-related complications. So such a good example of people taking that into their own hands and demanding more. I think that's like, I mean, that's like the America that I was raised to believe was possible. And like in those little corners, it's really borne out its potential. So I appreciate that a lot. And I think it gives me hope.
Me too. That's right. And you know, you give me hope too. Just hearing you. So we're gonna take a little break now. When we come back, Emily, I'd like for you to give us some information about how Montgomery County is doing in terms of prevention and in terms of you know, cases, and have there been an increase? Because I saw that nationally there's some populations that have been stable over the last few years. There hasn't been an increase, and there's some populations that has actually have a drastic increase. I wanted you to kind of give us a little insight as to which ones and why. So we're going to take a little, thank you. We're going to take a little break right now. My guest today is Emily Brown. She's the Ending the HIV Epidemic Program Manager from Montgomery County Health and Human Service, and we'll be right back. Welcome back. I'm James Sutton. I'm a person in long-term recovery. This is Road to Recovery, and my special guest today is Emily Brown. So Emily, we were just talking about so much, but we didn't get to talk about HIV in Montgomery County in terms of actually the statistics and, you know, what's the view of Montgomery County? How do we stand in terms of the nation? Are we like high or low in terms of new infections? How are we doing?
Yeah, that's a good question, and a loaded question. So Montgomery County has been chosen by the federal government. The reason that I have a job and that I've had this wonderful team working here on this issue to be a phase 1 jurisdiction for the Ending the HIV Epidemic initiative, which means that we are in the top half of jurisdictions around the country in terms of new HIV infections. And so we have been selected to basically come up with a jurisdictional plan to end HIV by 2030, which means to reduce new infections by 90% by 2030. We have about 4,000 people living with HIV in Montgomery County. We are next door to DC and Prince George's County that have also been selected as ending the HIV epidemic jurisdictions with their own plans, but we work together because this is a regional issue, just like everything else around here. Montgomery County is a really interesting place, really diverse, and our epidemic is diverse and interesting as well. We have a lot of resources here and this, you could be talking about anything. A lot of resources in this county. It's a wealthy county, but it's a county of entrenched inequality. And so HIV has always been, since the very beginning, an epidemic that has disproportionately impacted people who are marginalized from healthcare. It has often fallen along racial lines. It gets pigeonholed, I think, as a disease of behaviors and choices. But as time has gone on, and HIV has diminished in the general public for a lot of reasons, biomedical advancements, like nowadays, if you're in HIV treatment, you cannot, and it's successful, you can't transmit HIV to your partner. We now have, which is awesome, right? What a huge advancement. It's a 1 pill a day regimen for the most part. We have a pill, 1 a day pill that is very, very effective, depending on who you ask, 96 to 99% effective at preventing HIV infection in the first place. And that's recommended for people who are likeliest to get HIV. But people are still getting HIV because, well, in my opinion, our healthcare system has pretty much abandoned it as an issue. So we no longer screen people regularly for HIV. In Montgomery County, not so fun fact, from the moment someone contracts HIV to the moment they're diagnosed takes an average of 7.6 years, which means you might have contracted HIV and gone to your primary care clinician or your pulmonologist or the emergency department and gotten sicker and sicker and sicker over that time, but no one thought to ask you, do you want an HIV test or screened you for HIV just because it's, recommended by the CDC. So it's very unlikely that people who contract HIV will actually get diagnosed while they're still well, which is a huge issue. So I tend not to focus on, number of sex partners, condom use, or any of the other traditional ways to contract HIV. I tend to focus on how are our systems set up to find people living with HIV and then to get them into the very successful, very high-tech care that they need. And we're fortunate in Montgomery County to have free HIV treatment and free pre-exposure prophylaxis available here. So that's a little snapshot of our county. We have a lot of people living with HIV. Many are not in care. A lot are undiagnosed, and it's my job to make sure we diagnose more people. And then when folks are diagnosed, wrapping them in all of the services that they need to get into care, get to a place where they're undetectable, meaning that they have a small amount of virus in their body and they can't transmit it to another person because, again, they deserve to live a long, healthy life. And at that point, they cannot transmit it to others. So you got the healthcare goal and the public health goal, and together, that's what's going to help us end this epidemic.
Okay. Wow. Great snapshot. Now, not long ago, I looked at some data that said that one of the fastest growing populations of new infections were heterosexual women who didn't know they had it because the men were bisexual and they weren't telling their wives or their girlfriends or whatever. And that was a growing problem of people who didn't know that they were HIV positive because they didn't even know that they had a possibility. They weren't IV drug users. They weren't taking risky behavior other than unprotected sex. So what populations do you see? You said that because of the health disparities, that there were the marginalized communities, of course, but are there any age groups, or are more men or more women, younger people, older people, now that they got Viagra, are more older people getting HIV in the senior citizen homes, or what?
Yeah. Okay. Great question. So much to unpack. So, I want to go back to what you said about bisexual men and heterosexual women. Just to be clear, there was a period where that where we were talking about that a lot, and fairly I think like a narrative in mainstream society is that that gay or bisexual men were keeping something from their female partners, and that was how women were getting HIV. And to be clear, the research is really shaky around that. And
Okay.
and the truth is that, gay and bisexual men have vulnerability to HIV for a lot of reasons, but like all epidemics, like many epidemics, I should say most, and I should never say all, but things become concentrated in specific places, and it's not necessarily because, again, one group engages in more risk behaviors than another group, but gay and bisexual men have been disproportionately impacted since the beginning of the epidemic, and yet women, heterosexual or women from any of any sexual orientation, have always been impacted by HIV, and heterosexual men can get HIV too. And so it's really important just to remind everyone that it doesn't matter who your partner is or who your partner is sleeping with now, or who they prefer to sleep with. People who are, in monogamous long-term relationships can have HIV, right? So I just don't want anyone to think that, like, if someone does contract HIV from their husband, it's necessarily because he's bisexual. That bisexual bridge theory is super shaky. So sexual orientation is it's correlated with HIV risk, and I think of it again as like, for example, gay and bisexual men, how well is our healthcare system serving gay and bisexual men? Probably not so well. Are they getting the same level of care from their healthcare providers as heterosexual men? All the data that we have on that issue says that they're not. So are they going to the doctor, or are they avoiding going to the doctor? Are they getting access to resources, or are they not seeing resources that are tailored to their needs? So I try to focus on it from a systems level, but I think one of the reasons that we encourage healthcare providers to test everybody for HIV is that people always underestimate or totally misestimate their risk. And so I can't tell you how many people I've met who are just like, I had no idea. And if it hadn't been for their provider, finally ruling out everything else and wondering, why does this person keep getting sick, really sick with things that we never see, they would have never proactively gone and get a test, which is why the CDC has recommended since 2006 that healthcare providers routinely screen for HIV, regardless of, even if they ask someone what their risk might be. So it's an uphill battle. But if healthcare providers did that, we would recognize that a lot of people who are undiagnosed would never, in fact, have gotten tested on their own volition.
Right. Okay. Thank you. Now, on a systemic level, healthcare providers, because they're starting to ask questions about addiction. I see that's up front. Even in the doctor's office, up front, they're starting to be comfortable asking about addictions. But I think I've never seen anything about HIV testing. I see if you've had a history of HIV on your little check, would you check it, whatever your history is of diagnosis. Yeah. So do you see that coming soon, where that will be in the office and pretty regular, commonplace thing?
That's the goal. So we'd like people to start thinking, we'd like providers to start thinking like, especially if you practice in a place like Montgomery County or Prince George's County or DC that has what we call a high geographic risk, meaning we're a place that has a lot of people living with HIV. So just by virtue of where you live, if it's kind of like we've used some of these analogies with COVID. Like if you live in a place that has more COVID incidents, like you might accidentally forget your mask one day and still get COVID. Whereas a person with very little COVID could have, extremely risky behavior, never wear their mask and not get COVID. And mistakenly, we think, that this is about risk behavior. So if you're a doctor who has a practice in Montgomery County, and you have a patient in front of you, especially if that patient is sexually active or, or reports that they're sexually active, but, a lot of times people don't report that, don't want to talk about it at all because of our culture. Think about the fact that you're potentially missing an opportunity to save this person's life by testing them. You're going to take their blood anyway, right? We know that that's part of your job, to count all the other kinds of cells in there and make sure that they're doing okay. While you're at it, just order that extra test. The CDC recommends it. They're in a higher incidence area, higher prevalence area for HIV. If it's negative, great. You send them on their way. If it's positive, you have every tool in your toolkit to make sure that this person, A, gets healthy and lives their best life, and B, prevents transmission to other people. This is how we end an epidemic, right? It's not as big. HIV isn't as big of an epidemic as it used to be, but it steadily continues because we don't do basic things to stop it. And at our clinic here at Montgomery County, at Dennis Avenue, we see that systemic failure every day. People who've gone to their primary care clinician for years complaining about skin issues or persistently ending up in the emergency department for gastrointestinal problems. They start to get thrush. We're seeing people with Kaposi's sarcoma, which is usually only happening in people who are severely immunocompromised. It's 2022. That's unconscionable. Like, come on, it's a test. You're taking the blood anyway. Just get it done.
Right. So you kind of summed it up. We're about at the end, Emily. Now, I think we're gonna post where you can, if a person's HIV positive or interested in testing, and we're going to post your contact information, or if a person has any more questions and wants to contact you or the family members, we're going to post that along with the narrative. And so we're going to have you back so we could talk all day.
Yes, thank you so much. This was great.
So again, this has been Emily Brown. She's the program manager for ending the HIV epidemic in Montgomery County with Health and Human Services. This has been Road to Recovery. I'm James Sutton, and we'll see you on the road to recovery.